have my period for the last 3 months, 4 months, 6 months, you don't say that you are in a menopause. You only say if she's been without periods for 1 whole year. And that's when you diagnose, you suspect her that she has gone into menopause, and then you investigate her, talk to her and ask different questions and then confirm your diagnosis. So, but why does the menopause occur? The menopause happens because the function of the ovaries, the follicles which were present in the ovaries, they are exhausted, and there are no more ovulation taking place, so there is no more production of hormones, and therefore there is no more periods. In the this also happens in cases of somebody whose ovaries are removed because of some surgical problem diagnosis, or she has received a radiation because of some cancer, or she's undergone a chemotherapy or something. So whenever the ovarian function is depleted or not present, the menstruation stops and the woman enters into a stage of menopause. Similar is the case who go into premature menopause, who are those people who have got certain problems, genetic, or as I said, surgically their ovaries were removed, so they enter into menopause. So always make a diagnosis. If the woman is without a period for 1 whole year, that is how you make a diagnosis of a menopause. So WHO, they had conducted a workshop, and they divided the whole life cycle of a woman into sort of 3 phases. One was a reproductive phase, then menopausal transition phase, and a menopause phase. Menopausal transition phase, they described it as a perimenopausal phase, which starts about 4, 5 to 6 to 7 years before she gets her final period. So when the final period occurs, she doesn't have any period for 1 whole year, then she enters in a postmenopausal phase. So different changes take place in the transition phase, and then there are different changes taking place in the body of the woman in a postmenopausal phase. In the in a early perimenopausal phase, you would if you attend your clinics and all that, so you get females complaining of irregular menstrual cycles, or prolonged menses, or heavy menses, and then they also complain of some maybe some psychological symptoms which are related to this phase of their life cycle. And at this point in time, if you want to just augment your diagnosis and all that, you can try and do her FSH levels, and you will find them that mostly they are at a higher, towards the higher side. Now, as I said, during this period as well, a perimenopausal phase, her fertility definitely declines because she's not regularly ovulating, and then therefore because of that anovulation, her cycles are getting disturbed. They can be prolonged cycles and all that. And this, as I said, perimenopausal phase, it lasts about for an average of 5 to 6 years. Depend करता है on individuals. Sometimes it can be 2 to 8 years. Average is around 5 years. As said, how do you diagnose it? You do an FSH to augment your diagnosis. If it is higher, then you can predict that yes, you are somebody is in a perimenopausal phase. Now, the most common symptom which a woman presents in the perimenopausal phase is her psychological symptoms, which are vasomotor instability, that she complains of, that she's unable to sleep properly at night, she wakes up during the night, her moods are not, she's now very much short-tempered, she's become irritable, sort of a depressive moods at times. And because of this disturbance in night and these hot flashes which she gets during this vasomotor period, her sleep is disturbed, which results in fatigue in the morning, and then there can be headaches, there can be migraines. If she is already suffering from migraine, they can be, exaggerated in this time period. So all these symptoms, they can present with any one of these symptoms in a clinic in a gynae clinic. So how do we manage these females who are presenting with menopause? The first and the foremost thing is that we need to assure them that there is nothing abnormal happening to them. This is try to explain to them the physiological changes which are happening in their body at this point in time. And then we need to inform them that how can they can help themselves, and how the medical practitioner can help them in going through this transition. Then second thing which we, since she is not ovulating, and she's, when a woman is not properly ovulating and ovulatory cycles are, there is continuous estrogen. So this is the time when she can develop endometrial cancers and all that. Her endometrium becomes hyperplastic, which can transition into a cancer. So our goal is again to prevent this thing happen, and then providing obviously symptomatic relief to her from her hot flashes, controlling her heavy menstrual cycles, controlling her mood disturbances and all that. So there are certain things which are important, and we have seen that some people who are, who sort of enter into menopause earlier, or maybe there are some people who are more affected by the symptoms than compared to the others. So factors which affect the menopause, obviously, if a woman's mother has gone on menopause at an early age, she will enter into menopause at an early age. Or if her mother had a late menopause, there are chances that she will have a late menopause. Tobacco somehow or the other affects the menopause because it affects the hormonal levels. Alcohol, again, her increased BMI, those people who are towards a obese side, they have a difficult perimenopausal period. Similarly, alcohol consumption also affects because there is lack of nutrition, they don't take much nutritious diet, their body weight increases, and this also these things they affect on her transition into menopause. But again, the use of contraception, and her parity and all that, has got no significant effect on that. And these symptoms, they gradually over the time of, as I said, average 5 years, but sometimes people stop having all these perimenopausal symptoms earlier. All they need is support, assurances and psychological support, and if required, some symptomatic relief. So these are just the fact that, what do we say, premature menopause, that if somebody enters menopause before 40 years, and that happens usually because of some surgically ovaries were removed, some cancer, chemotherapy and all that. And then late menopause is beyond 60 years of age, right? So this is what we see. This is just dramatic how the symptoms appear. So this is the time when the menopause occurs. This is the time when she has no period for 1 year. Before this is a transition period. Now in this transition period, she is having these problems, and she's having menstrual disturbance. But once she enters into her menopause, the symptoms which now generally more seen are some related to her genital tract, right? Genital tract. And then later, towards around another difference is around 5 to 10 years into her menopause, these symptoms which are presented are she presents with osteoporotic fractures of the bone. She's got atherosclerotic changes in her vessels. She might end up with a coronary disease, having an MI, or ischemic. This is just again the same thing, which are at a glance, that how clinical criteria is that no period for 12 months, around the age 40 when you are endowed to an FSH and estrogen. So these are the symptoms which you see: instability, metabolic changes. Now, what are the metabolic changes which occur in a woman? They are, I'll as we go further into the slides, and I will explain it to you what happens to the metabolic changes. Now, this is what happens. This is the commonest symptom. 85% of the females they suffer from, but only 25 to 30% they present to you in a clinic for for a doctor to help her out of this symptom. And this is what it is. There is a sudden gush of warmthness which starts from the upper body and goes up right up to the head, and then there is redness, and then there is sweating at night. When this happens, we call it night sweats, but during the daytime we call them, it's known as hot flashes, and usually seen in females who have got a raised BMI. And it can last for a variable period of time. How do we manage these hot flashes? These are most disturbing symptoms to the female, and this can happen when she comes to you for your guidance and all that. Number one is assurance. Number two is that you need to tell her how to help herself, like decreasing the room temperature while going to the sleep at night by opening the windows and letting the fresh air come in, or putting on an AC, taking a bath before going to bed. Don't take teas and coffee at night time, and this is they help them quite a lot. But again, we have certain medicines, non-hormonal medications, which can help in fighting with these symptoms if they are not being managed by the other advice which has been given to the female. And in them, these are the selective serotonin receptor, paroxetine and fluoxetine. Or non-epinephrine inhibitors, these ones, or gabapentin or clonidine. Now, all these things, they have quite a good effect on controlling the vasomotor symptoms, and they take about 2 to 3 to 4 weeks, and need to be judiciously managed, and not to be given for a long time or excessive. As far as the cognition is affected, well, there is not medical evidence, no medical evidence as such that a perimenopausal or a menopausal female, her cognition decreases. But what happens is that because of her changes in her mood and her irritability, yes, at that point in time, she does feel that her, some sort of a short-term memory, that is little affected, that she forgets where she has kept her keys, or she forgets her doing something, what should we want to do, and it just slips her mind and all that, which makes her again irritable. And probably that is said that because of her, she's not sleeping well at night, and she's fatigued, and she's irritable, that leads to that. But yes, later in the lifetime, when because of a prolonged lack of estrogen, and it can lead to some effect in the your ischemic strokes, can cause ischemic strokes and all that. That can affect her mental capability, and the woman can develop dementias beyond age of 65 or 70 or that sort of thing, right? Now, this was the metabolic syndrome which I was talking. Now, females think that, well, since they have reached the menopause, or they've, in a transition phase, they have started to put on weight, or if you put them on HRT if they require, and they say, when since I've started my HRT, my weight has increased. That is not true. Beyond 50 years of age, beyond 50 years, it's like 1 year per kilogram increase in weight of a woman, and this is because changes in her lifestyle. Now she is no more very much active. Her nutrition wise, how we people eat in Pakistan, and there is lack of exercise. So these are things, and then again, because of her changes which are happening in the body, because of the lack of estrogen and all those hormones, her lipid profile that changes completely. Her cholesterol level raises, triglyceride rise kar jate hain, HDL, which is a good lipoprotein, it decreases, bad lipoprotein LDL increases, and her she develops insulin insensitivity, resulting in decrease. At this point in time, she might develop diabetes and all that, hyperinsulinemia. So these are the factors which contribute to her weight gain. And then these are the factors, if they are not the controlled in the life, then they can affect her cardiac health. It can affect her vascular health and all those things. So as you see in this slide, earlier when the females in a younger phase, the incidence of cardiovascular disease is more in the males as compared to the females. But once she enters into menopause, beyond 60 years, her incidence of cardiac diseases is comparable with that of the male. And this is all because of the changes which is happening in her cholesterol and in her weight gain and in her everything, which leads to all these, which leads to the effect in the cardiovascular system. Now, this is one most important thing which is need to be seen, and it is osteoporosis is called a silent killer, right? There are no symptoms. The only symptom you get is when you fracture your bone. When the person fractures the bone, that is the only time a person realizes they have osteoporosis, they have developed osteoporosis. And this osteoporosis sets in around the time of perimenopause. First 5 years menopause के sharp decline होता है in bone mineral density के अंदर, and then it stabilizes, but it then keeps on decreasing over the years, and beyond 60-65 the person becomes more vulnerable to vertebral column fractures and femur fractures, and this is all because that the remodeling of the bone, which is taking place in the adult life, in which the osteoblast and osteoclastic activities are occurring in a well-balanced manner, that is disrupted because of the lack of estrogen later in the life of the female. And osteoclastic activities is markedly increased. There is not much remodeling of the bone. No more bone is being formed, which results in the fragility of the bones and resulting in the osteoporotic fractures in the female. These are the urogenital symptoms, which in the last few slides back I showed. You saw that these are the symptoms which starts developing around close to 60 years of age, when she starts developing dyspareunia. She has her vaginal dryness, and then there is this repeated urinary tract infections, and at times because of so much of vaginal epithelium has become so thinned out that the vaginal stenosis occurs. And these are all because of the fact that the uroepithelium and the vaginal epithelium, they all have estrogen receptors, and because of the lack of the estrogen receptors, these epitheliums, they become thinned out, and they are unable to protect against the infections and all that. And if you examine a female of postmenopausal and you do her per speculum examination, you will find her at vaginal epithelium very thin, very pale, and sometimes there are petechial hemorrhages in it, and this is all because of the lack of the hormonal which are in her body. So now, how do we manage females in this phase of her life? Now, remember that every female doesn't require hormone replacement therapy. We have to tailor this therapy according to the symptomatology with which she presents. There's no blanket cover that you can give hormone to everybody. No. We previously, since after we had this women health initiative studies, there was lots of changes which took place, and immediately after the publication of that study, everybody stopped prescribing hormones, and there was a sort of a hell broke out, because all those females who were already on hormone replacement therapy, their therapies were stopped, and they suddenly developed the symptoms. But then again, there was lots of sort of a, you can say, hue and cry, and they started analyzing that study, the researchers and everything, and then they found out that there was lots of flaws in that studies, and then they made a guidelines how to prescribe hormone replacement therapy to a woman, and that the baseline of that was that there is no blanket statement that you can give it to everybody. All you do is that see the symptomatology of the female, and then try to help her out with the hormonal therapy or with the non-hormonal therapy, whatever is suitable for her in that circumstances. So we have different treatment options. We have non-pharmacological options, we have pharmacological options. Among the non-pharmacological options, lifestyle modification is one of the major factor in helping the women out of her predicament. And what are the lifestyle modifications that she can do? If she's a smoker, then she has to stop smoking, because it has one beneficial effect on her bone health. It has a beneficial effect on her cardiovascular health, and obviously it prevents from lung cancer and all that. Then if she consumes alcohol, she has to either stop it or decrease her consumption of alcohol. As I said, weight is very important to maintain at this point in time. With 1 kilogram gaining weight every year, so one can end up with hundreds of kilograms. It's better that you should start exercising at this point in time. If you have not been exercising earlier, start going out for a walk, 30 to 40 minutes of a brisk walk daily, if possible, otherwise at least 3 times in a week, and change in dietary habits, and go towards a more healthy and beneficial good diet, which does not increase your cholesterol levels and let's increase your weight, helps in increasing your weight. And therefore in decreasing your weight, again, it has a very good effect on the bone health, on the cardiovascular health, on the this thing, your reduction in endometrial cancers and all that. So one has to really see it in a whole broad perspective and bring about the changes in the life. Although females, if I say that talk about, particularly point out the females of Pakistan, we are not a very sort of active lifestyle we have, but this younger generation which is coming up, they do go to the gyms, and they do go try to maintain themselves in a better health than the my generation or a generation before me. So then the second thing are the natural herbs which are being prescribed. Well, there is not as such any medical evidence base that we can how effective they are and for how long they can be given. But yes, they do improve onto the symptoms because they are mild, they have mild hormonal this thing ingredient in them, it's mild estrogenic activity. But then again, prescribing them, before prescribing, one has to have a good history of a person to whom you are prescribing. Then other therapies like acupuncture, reflexology, and aromatherapy and all that, they are if somebody is not very much inclined, or somebody is not a good candidate for an hormone replacement, then these are the therapies which can help them in overcoming these problems. And then again, obviously, as I said, diet and changes in the diet and your intake of calcium and vitamins and all. Now, among the pharmacological therapy, we have this hormone replacement therapy, and these are the non-hormonal pharmacological products. These products, as I mentioned earlier as well, these are good products which can be prescribed if somebody is suffering from a vasomotor symptoms, because they do have a very good and a beneficial effect in controlling the vasomotor symptoms, and they can be given for a couple 1 year or 6 months, or depending upon how the person responds, and then how once you stop them, do the symptoms return, or the person has passed through that transition phase of transition. So these are the botanicals, which I said, all those herbs and all that, natural herbs. These, now we come to a hormone replacement. So we have a group of hormones. We have estrogens, we have progesterones, then we have androgens, and then we have tibolons, and also then we have certain selective estrogen receptor modulators, and then medicines which are bisphosphonates, which are non-HRT, but are given for the bone health and all. As I said, this is what the Menopause Society has said: individualize and tailor according to the symptoms. Lowest dose for the shortest possible time in natural menopause. But in case of females who undergo premature menopause or premature ovarian failure, those are a very highly vulnerable group. In them, we need to prescribe them for a longer time, to till the longer time is such that they reach their own natural age of menopause. Now we have different medicines, as I said, estrogen, progesterone, combination of estrogen and progesterone, tibolons, and so on and so forth. So among the estrogens, what are the things we have? Now, estrogen, we can give them orally. Estrogen, we can give them in a form of a patch, or we can give them in a form of a cream, or we can give it in the form of a gel. So as the estrogens are there, we have estradiols, we have micronized estradiols, we have transdermal patches, and these conjugated equine estrogen, now we have a lowest possible dose available, this 0.3 in Pakistan, and this can be given to a female. Then among the progesterones, we have medroxyprogesterone, We have micronized progesterone, dydrogesterone, naltrexone acetate, drospirenone, and then we have progesterone in the form of an intrauterine device, which is known as intrauterine system. Then this transdermal patches. अच्छा, the oral estrogen जो है वो can only be given to those females जो hysterectomized हो चुकी हैं, ठीक है ना? We let's go to the details quickly because I think we have got 10 minutes left only. So vaginal creams are given only to the females who have complaints of atrophic vaginitis or more of a urinary. Local जो है ना benefits इसका ज़्यादा होता है. Progesterone preventing of hot flashes में दे सकते हैं आप, and along with the estrogen therapy. This is if somebody is getting estrogen therapy to prevent endometrial hyperplasia, we can prescribe this this system LNG, Mirena, which is known as Mirena in a commercial business. Then Tibolone, this is something which has got androgenic, estrogenic, progesteronic activity, and this is very good in controlling vasomotor symptom. It has got a beneficial effect on the bones as well. And androgens in the form of testosterone patches for the females who have got problems with the decrease in libido, vaginal dryness. These are they improve their sexual health. How it is given, as I said, if the woman is hysterectomized, then we can, without any problem, we can give her continuous estrogen to alleviate her symptoms. But if the woman has her uterus is present, then we have got two type of therapies. Either we give them a sequential therapy, that is, we give them estrogen for first 12 to 14 days, and then in the last 10 to 12 days we add progesterone along with that, and then at the end of 21 to 28 days we stop, and she bleeds, right? And then we again start the cycle. If a woman has been in menopause about 4 or 5 years and all that, and she doesn't want a bleeding pattern, so we can give her a continuous combined therapy in which the estrogen and progesterone are given continuously to her throughout the therapy. She doesn't menstruate, and this for her symptoms and all. Before prescribing any treatment, we need to assess the person, take a history, any contraindications, relative and absolute, discuss with them about the risk and the benefits, do her examination, her blood pressures, do her baseline test, know her fasting lipid profile, her insulin and sugar levels, mammography, and her bone scan. These are the absolute contraindications. Any undiagnosed bleeding, endometrial CA, active or recent history of thromboembolism, any liver disease, any clotting disorders, and these are the relative contraindications to her. So these are the females who have they can't get anything. These are just the graphs to show you how does this hormone therapy helps. See, you give her a estrogen or a progesterone, and look, her vasomotor symptoms within 3 months they just come down to the minimum level, as compared to the other therapies which if they are prescribed to her. A urogenital system, better is that you give her a local treatment, vaginal creams, vaginal rings, vaginal gel, that will help in improving her, the local environment and all that, and her dysuria and dyspareunias and all those things, they improve. For sleep and all that, as I said, non-hormonal therapies like SSRIs and clonidines and fluoxetines and all that, they are very good. You can give them to. For bone, yes, this is a very important topic, and for bone health, early in the lifetime, once she enters into menopause, for the prevention of osteoporosis, the woman can be put on hormone therapy. She can also be put on bisphosphonates or SERMs to prevent. But beyond 60 years of age, to prevent osteoporosis, that is not recommended. We have both these things, and then we have Tibolon. Then we have, this is the 4th generation selective estrogen receptor modulator, benzodoxifin, along with estrogen, which preserves the BMI. नॉन हार्मोनल थेरेपी में कैल्शियम, विटामिन डी आप हर औरत को कहते हैं जो मेनोपॉजल हो रही होती है, पेरीमेनोपॉजल के, एटलीस्ट 1200 milligram of calcium she has to take every day without fail, along with vitamin D if she is deficient in it. Then bisphosphonates, these are good for preventing bone resorption and all that. Then we have the selective estrogen receptors modulator in the form of loxifene, lexifene. This is the 4th generation which has been recently introduced, and it prevents your vertebral and non-vertebral fractures. Then we have parathyroid hormones, then strontium, and this is monoclonal antibody which is given every 6 months to decrease the vertebral and non-vertebral. Now, so as far as the cardiac health is improved, yes, early, if you start it early, you can help a woman in preventing cardiac. But if you start late, beyond 60, then instead of helping the woman, she will end up with an MI. साइड इफेक्ट्स ईस्ट्रोजन के जो आपके देखने में आते हैं, कॉन्ट्रासेप्टिव्स जो लेती हैं खवातीन, उनको साइड इफेक्ट्स होते हैं, वही टाइप के साइड इफेक्ट्स HRT से हो सकते हैं. Now one has to balance the risk and the benefit in giving, and the benefits, if you find in particular individual that the benefit is more as compared to the risk, then please do prescribe them. I'm going to go very quickly to these things. As I said, less than 60 years, good to give them HRT to prevent the heart diseases, but beyond that, not recommended. Similarly, stroke का incidence age के साथ increase होता है. अगर आप early देंगे तो इतना ज़्यादा problem नहीं होगा, but if you go on late, different problem हो सकती है. Oral से ज़्यादा हो सकती है, but if you give them a patch that चूंकि वो liver से pass नहीं करता, तो इसका effect जो होता है ना, वो इतना deleterious नहीं होता है. ब्रेस्ट कैंसर में yes they say कि जी ब्रेस्ट कैंसर 1 in lifetime जो है ना 1 in 12 होता है. HRT से थोड़ा सा इंक्रीज हो जाता है, बट once you stop it वो वापस आ जाता है. इसलिए अगर किसी को मेमोग्राफी आपने करा ली है, लो रिस्क पर है, उसका कोई मसले मसाइल नहीं है, उसको अगर वो पर्सन सिम्टोमेटिक है तो आप उसको HRT दे सकते हैं. एंडोमेट्रियल कैंसर कंबाइंड में थेरेपी में कोई कैंसर का चांस नहीं है, लेकिन अगर किसी औरत को अनडायग्नोज्ड वेजाइनल ब्लीडिंग है, पहले आप उसको DNC करें, उसको डायग्नोज करें, कोई प्रॉब्लम तो नहीं है, ओनली देन यू कैन प्रिस्क्राइब. सिमिलरली अगर ऐसी खातून है कि जिसको आप देना चाह रहे हैं ईस्ट्रोजन्स, तो और उसका यूट्रस इंटैक्ट है, तो एज आई सेड अर्लियर, आप उसको ईस्ट्रोजन ओरली दे सकते हैं और प्रोजेस्टेरॉन इन अ फॉर्म ऑफ मारिना उसका यूट्रस में रख सकते हैं, जो कि एंडोमेट्रियल हाइपरप्लेसिया को बचा देगा. प्रोजेस्टेरॉन ऑल्सो हैव अ गुड इफेक्ट. आप इसको प्रोजेस्टेरॉन जो है आपके जो वेसोमोटर सिम्टम और इनको जो है कंट्रोल करने में मदद देते हैं. और क्या कहते हैं, जिसका जो एंडोमेट्रियल हाइपरप्लेसिया को कंट्रोल करता है, जो ओवुलेटरी एंड ओवुलेटरी साइकिल्स के अंदर खवातीन चल रही है. दिस इज अ वेरी गुड ड्रग, जो कि आप अगर एक खातून जो है उसको 1 साल कंप्लीट हो चुका है मेनोपॉज का और उसके पास सिम्टम्स उसको आ रहे हैं बहुत ज्यादा, तो आप इसको टिबोलॉन 1 टैबलेट डेली के हिसाब से प्रिस्क्राइब कर सकते हैं. ये उसके सारे सिम्टम्स जो है ना, वेसोमोटर सिम्टम्स और उसके जो वजाइनल ड्राइनेस के सिम्टम्स जो सेट इन हो रहे हैं, सबको कंट्रोल करती है. एंडोमेट्रियम पे इसका प्रोजेस्टेरॉनिक इफेक्ट होता है, इसलिए कोई हार्म नहीं करती, ब्रेस्ट के ऊपर कोई हार्म नहीं करती, और आपका पेशेंट को जो है ना बेनिफिट इसका ज्यादा. Similarly, we have these SERMs. This is good for preventing and treatment of osteoporosis. And then these are the 2 drugs which have been introduced recently. So we are done with this, and if you have any questions, I can